Hello and welcome, everyone. Thank you for joining us this afternoon, evening, or morning, wherever you may land. My name is Antu Hossain. My pronouns are she, her, and hers, and I am the Global Health Impact Officer at CanWaCH, the Canadian Partnership for Women and Children's Health. Today, we are very, very excited to be joined with an amazing panel. And so before I go right into that, I do want to recognize that all of us may be joining from different locations today, many of you in the comfort of your home, I hope. For me, home is Toronto, and I'm grateful for the stewards of the land who have made it possible for a settler like myself to live, work, and play on the traditional lands of the Haudenosaunee, Wendat, and most recently the Mississaugas of the Credit. I am joined today by my colleagues Jessica Ferne, Director of Global Health Impact, as well as Julia Anderson, Chief Operating Officer at CanWaCH as well. So I'm actually going to hand it over to Julia to give us a few opening remarks.
Welcome, everyone. So excited to have you all here this afternoon. And on this anniversary of the 2019 Women Deliver announcement delivered by the Prime Minister, making Canada the leading global donor in SRHR, with a focus, of course, on the neglected areas, including access to and advocacy around abortion issues. And with so much going on in these past weeks and months, we've really had an opportunity to think about the ways that access is enabled and access is denied to services such as abortion services. And in a time when we're all at home and in various forms of isolation and self-isolation, we know that issues like this, like abortion or any women's rights issues, face additional challenges. So I think it's really exciting to be here with the collaboratives, an initiative of CanWaCH to work in partnership with some really smart people, which I think that's how I like to sum up the collaboratives. We brought together a lot of big brains on important subjects to pursue a better understanding and a deeper understanding of data gaps. And so, of course, issues, neglected areas such as this that's a critical lens to see these gaps through, and how can we really understand the challenges and understand the problems if we don't have the data to back it up. So I am just so excited to hear from Jill and Angel and to hear about what their collaborative is doing, and just have been really grateful for the partnership that CanWaCH has had with them to tackle this really important issue. So with that, I'll pass it back to you, Antu, to do some introductions, I believe.
Awesome. Thank you, Julia. And absolutely, we are so thrilled to be having two wonderful leaders in this area of abortion data and abortion advocacy. So without further ado, if I can introduce them, Dr. Angel Foster is the professor in the Faculty of Health Sciences and the 2011 to 2016 Endowed Chair in Women's Health Research at the University of Ottawa. Her research focuses on emergency contraception, abortion, and health professions education, and she leads projects in 22 countries. In 2017, she received the Guttmacher Institute's Darek Award for Excellence in Sexual and Reproductive Health Research. She's also the recipient of the inaugural Leadership Award for the Canadian Partnership for Women and Children's Health and Society for Scientific Study of Sexuality's 2018 Public Service Award. Dr. Foster will be starting our presentation, and then she will be handing it over to Jill Doctoroff. Jill Doctoroff is the Canadian Director at the National Abortion Federation and supports NAF Canada. The bulk of Jill's career has been in the nonprofit sector, serving as the Executive Director of the Elizabeth Bagshaw Women's Clinic, the Asian Society for the Interventions of AIDS, Asia, and the Planned Parenthood, Ottawa. Jill serves on the boards of directors for NAF and Canadians for Choice. She is currently the past president of the board of directors of Options for Sexual Health. Jill has worked and volunteered in abortion care for more than 15 years. So I am thrilled, as you can tell, to introduce these powerhouses of wonderful females who will be sharing their expertise in this specific area. And then after the presentation, we will be guiding into a discussion period. So please feel free to offer your questions throughout the rest of the presentation in the Q&A box. And over to you, Angel.
Well, first, thank you so much, Antu, for the introductions. Thank you to Julia, to Jessica, Tina, and Erin, and everyone from CanWaCH for organizing the webinar today. And many thanks to all of you who have taken time out of your day or evening to join this discussion. So on behalf of our teams in Asia, the Middle East, North America, and Sub-Saharan Africa, Jill and I are delighted to share an update on a global initiative dedicated to collecting data on abortion in humanitarian settings. As Antu said, my name is Angel Foster. I'm the PI of this project, and my pronouns are she, her, hers, or anything respectful. So over the next 35 minutes or so, we're going to give you an overview of the project and share a bit about what we have been doing and where we're going. I'll begin by providing some background information on sexual and reproductive health in general and abortion in particular in humanitarian contexts in order to provide the rationale for our CanWaCH project. I'll then describe the aims of that project, as well as highlight findings from our work in Jordan. As I'll explain in the presentation, this project has now become nested, if you will, within a larger project led by my colleague, Dr. Lulu Kubesi at the World Health Organization. And I'll talk a little bit about this broader project and what the next steps are. I'll then turn this presentation over to Jill Doctoroff from NAF Canada, and Jill will describe the advocacy component of the project. And she'll reflect on the lessons that we've learned from collecting data about abortion in Canada and the role that Canada can, and I would argue indeed should play, in ensuring that abortion is included in sexual and reproductive health services and data collection in humanitarian settings and beyond. After that, we'll open it up for questions. I also just want to say from the outset that this is very much a work in progress, and as I'm sure is the case with many people on the webinar today, the COVID-19 situation has required us to alter some of our timelines and adjust our work plans, and our presentation really reflects the evolving nature of this project. Next slide, please. As I'm sure everyone on this webinar is aware, as a global community, we are in the midst of an unprecedented humanitarian crisis. According to the United Nations High Commissioner for Refugees, more than 70 million people live in the world as refugees or internally displaced persons. And about half of those needing humanitarian assistance are women and girls of reproductive age. At any given time, about 5 million people in humanitarian settings are pregnant. Research from around the world is strikingly consistent and indicates that women and girls in humanitarian settings are at risk of rape and sexual violence, early child and forced marriage, unintended pregnancy, unsafe abortion, complications from pregnancy or during pregnancy and delivery, sexually transmitted infection and HIV acquisition, as well as other forms of gender-based violence. And we can talk a little bit more about this in the discussion, but there is emerging evidence and anecdotes that suggest that many of these risks are or could be heightened in the COVID-19 era. Next slide, please. We know that data collection in humanitarian settings, both in general and on sexual and reproductive health or SRH issues in particular, we know that data collection is important, but we also know that it's complicated. Data collection on SRH in humanitarian settings is important because in collecting data, this information can inform programming, it can help us identify successful interventions, and it can help us to secure and sustain resources. However, we know that data collection on SRH in humanitarian settings is also complicated and is often uneven. The data that are collected both within and between settings is often inconsistent and quality and is not necessarily the same in comprehensiveness. We know that disruption and diversity of systems, services, and stakeholders makes routine data collection tricky. And we also know that there's often a lack of clarity about what to do or what is being done with all of the data that are collected. We also know from assessments done by the Interagency Working Group on Reproductive Health in Crises, or IWAG, among others, that abortion-related data collection in humanitarian settings is even more limited than SRH data collection in general. And one of the things that we find is that when abortion data aren't collected, this is often used as quote unquote evidence that there's no need for abortion services. And finally, while we understand that these challenges exist, there is generally a lack of knowledge about what could be done to facilitate routine, high quality, value added data collection in humanitarian settings. Next slide. So given this overarching context, agencies that work in the abortion space have long identified abortion-related data collection in humanitarian settings as a priority. However, there are a couple of other events that set the context for our project. First, in November of 2018, IWAG released the 2018 Interagency Field Manual on Reproductive Health in Humanitarian Settings, or the IAFM. First published in the mid-1990s, the IAFM provides authoritative guidance on SRH service delivery in all phases of complex emergencies. And importantly, for the context of this project, the 2018 IAFM updated the Minimum Initial Service Package, or MISP, and that is the priority set of life-saving interventions to be provided at the outset of an emergency. And the 2018 IAFM also provided guidance on what types of data should be prioritized for collection at different phases of an emergency, and used a less is more framework. And what that means is that in most cases, this involved focusing on 3 key indicators for each topical area of SRH covered in the manual. The release of the 2018 IAFM provided a window of opportunity to engage or re-engage in discussions about data collection in humanitarian settings. And in addition to prompting discussion about abortion-related data collection, the rollout of the IAFM offered an opportunity to incorporate data collection into broader training efforts. Finally, as Jill will discuss in more detail in a few minutes, over the course of the last few years, the Canadian government has identified comprehensive abortion care as a neglected and priority area and was willing to support work in this space. Next slide. So given this confluence of events, the time was really ripe for this initiative. And we're very grateful to CanWaCH for supporting this collaborative, which is a collaboration between my group at the University of Ottawa, NAF Canada, IWAG, and local partners. We started in January of 2019, and our original plan involved 5 phases. First, we aimed to conduct assessments on abortion-related data collection in 3 settings, and that was Bangladesh, Jordan, and Somalia. Our second phase was dedicated to developing and training materials to facilitate data collection. And then in our third phase, we intended to implement and evaluate an intervention that involved using those resources. Phase 4 was about refining and distributing the tools and training materials through broader networks, including through IWAG. And then the final phase in our initiative, although I will say some of this was always intended to be going on simultaneous with the other phases, was to really advocate for continued prioritization of abortion with the Canadian federal government, as well as with other global stakeholders. Next slide. So in terms of our initial assessments, we aim to address the following questions. First, what are the primary challenges to routinely collecting the abortion-related data outlined in the 2018 IAFM? Second, what resources could be provided to help stakeholders collect these data in all humanitarian settings, irrespective of location, type of emergency, and the legal status of abortion? And 3, what could we do with these data to ensure that they are relevant to policy, service delivery, and advocacy? Next slide. The 2018 IAFM outlines the abortion-related services that should be provided at both the outset of an emergency and once the situation stabilizes and there is a transition to comprehensive service delivery. I've outlined these services on this slide here, and I'm happy to talk more about the nuances of these guidelines during the question and answer period. But if we go to the next slide, the point that I really want to drive home here is that the abortion-related data that we are exploring align with the expected abortion-related service delivery that is outlined in the 2018 IAMF, and that the abortion-related data that we're exploring are all facility-based. So for example, if as part of the MISP, agencies are expected to offer people who have become pregnant as a result of rape, either a referral for an abortion or an induced abortion on site, we would expect that facilities would be able to capture the number of people requesting and receiving that care from the outset of the emergency. Next slide. Our initial assessments involved a multimodal study design that included key informant interviews, data collection mapping exercises, resource and technology inventories, observation sessions at key facilities, and focus group discussions with frontline staff. And I just want to note here that we received overarching ethics approval from the Research Ethics Board at the University of Ottawa, and then received local approval to conduct the research in each specific setting. And who approved the research in each setting was very setting specific. Next slide. So we completed our first assessment in mid-2019 in Jordan, and I've outlined kind of the different components of the assessment here. We included facilities and stakeholders that were serving Syrian refugees in both camps and in urban settings. And I'd really like to give a shout out to Majd Hamed and her team at the Tri-Center for Research, Education, and Training for their work on this project with us. So what we found in Jordan was that first, abortion-related data are extremely limited and inconsistent. And basically, no data were being collected on induced abortion in a routine way. Although several organizations providing services to Syrian refugees would make referrals for abortion care, typically to private sector providers, only one organization documented these referrals with any degree of consistency. And finally, most organizations that were providing services both in camp and urban settings collect some information about post-abortion care, but they don't differentiate between post-abortion care or PAC for spontaneous miscarriage versus an induced abortion, particularly when that's outside of the facility and done unsafely or less safely. Our stakeholders in this study identified a number of barriers to routine abortion-related data collection. And this included confusion over the legal status of abortion in Jordan and what that means for data collection around this topic. Stakeholders also had a great deal of confusion over the US government's funding restrictions on abortion and what that means for data collection if the organization receives US government money or is the recipient by way of another organization of US government money. And finally, there was a widely held perspective that collecting abortion-related data is unnecessary. But I will say people were split as to why it was unnecessary. Some believed that it was unnecessary because there isn't a need for abortion care. There's no evidence that there are abortions and therefore we don't need to collect information about abortion. But others believed that there was actually a lot of abortion taking place, but that collecting data wouldn't necessarily change programming and therefore wasn't a priority. I'll just note here that our findings from Somalia are actually quite similar, and many thanks to the team at the Fatima Halain Foundation for their work on this project. Our findings in Somalia indicate that there's no routine collection of abortion-related data at facilities serving refugees or displaced persons, and some of the same challenges were really highlighted. Next slide, please. So in terms of our recommendations after some of this initial work, first was that there is a real need to provide clear guidance on what should be collected around abortion and why. Second, there's a need to provide tools and materials to facilitate data collection, including how to protect the identity of both patients and providers. Third, there's a need to address concerns about legality and funding and to really clarify what the regulations and rules and policies are. We also felt that it was important to highlight that efforts to support data collection around abortion really should be accompanied by values clarification activities more broadly. And then finally, one of our findings from these initial assessments is that external requirements could actually enhance accountability. And by external requirements, I mean requirements from implementing agencies or from the SRH coordination structure or health cluster, requirements from international agencies or UN agencies, or requirements from bilateral donors. Next slide. So as we were moving forward with our project, my colleague at the WHO, Lulu Kobisi, was developing a project dedicated to developing a core set of sexual, reproductive, maternal, newborn, child, and adolescent health indicators for routine collection in humanitarian settings. In December of 2018, Lulu and her WHO colleagues convened a number of global stakeholders in Geneva, and through a consultative process created a candidate list of more than 70 SRM and CAH core indicators. These included both field level and population level indicators and were derived from both authoritative and normative guidelines. Developing the core set of indicators was the envisioned first step in a multi-phased project. And of course, it would be critical to determine the feasibility of collecting these indicators at the field level. And then in terms of the overarching project goal, once there was agreement on the indicators, there was a desire to develop tools and interventions to facilitate routine data collection in humanitarian settings. Next slide. So although these projects are different in scope, there's obviously a lot of synergies between our CanWaCH project and the WHO's indicator project. And so since last fall, my group at U Ottawa has been collaborating with Lulu and her team at WHO on this larger initiative. Drawing from the methodology that we developed for the CanWaCH project, my research group, in collaboration with local partners, the WHO country offices, and Lulu's team, are now conducting a concurrent multi-methods study to explore the feasibility of collecting these indicators in 7 humanitarian settings. And these settings have been purposefully selected to reflect diversity in region, sociocultural context, type and phase of the emergency, and location of refugees and displaced persons. And based on the findings from our study on abortion-related data collection in Jordan and with input from the IWAG Safe Abortion Care Sub-Working Group, we've actually incorporated a set of abortion-related indicators into this candidate list of core SRH indicators. Collection at the field level is ongoing, and I'll just say the COVID-19 situation has caused some delays, but our hope is to convene a group of global stakeholders in the fall of 2020 to achieve consensus on a core set of SRMN-CAH indicators. And then as WHO moves forward with its dissemination and resource development efforts, the abortion-related tools that we are developing through our CanWaCH project will be incorporated into this broader plan. Next slide. So the scope of our original project has expanded considerably. The 3 original countries from our CanWaCH project are listed here with an asterisk. We completed standalone abortion-related assessments in Jordan and Somalia. And just as a note, Somalia is not part of the WHO project. But then we also conducted the SRMN-CAH feasibility assessment in Jordan about 6 months after we had completed the standalone Jordan assessment. And I'll just say that rarely do you get an opportunity to replicate a study of this kind within this kind of time frame, and it actually was really valuable and confirmed our original findings. Ultimately, we'll be able to use the abortion-related findings from all 8 countries, assuming that those that are in the works move forward, and we'll be able to use that information to move forward with recommendations and advocacy around abortion specifically. Next slide. So in terms of our next steps, we are finalizing our field level assessments now, and we'll be coming out with a series of articles and reports focused on both the larger WHO project and the abortion-related CanWaCH project. So stay tuned for those resources. Lulu's team at WHO has their own well-defined dissemination and implementation plan, but our CanWaCH collaborative is currently working in several countries to create tools and resources to facilitate facility-level data collection on abortion services, and we have a monitoring and evaluation plan in place to assess uptake. IWAG is obviously a key partner in this initiative, but I will say the CanWaCH project feeds into a broader effort led by the Research and Data Sub-Working Group of IWAG to develop a compendium to the 2018 IAFM that will provide detailed guidance on collecting core SRH data in humanitarian settings. And then as part of our CanWaCH project, We have an advocacy plan to engage with the Canadian government and Canadian stakeholders to ensure that abortion remains a core part of the sexual and reproductive health and rights agenda. And so with that, I will turn it over to Jill to talk about some of this advocacy.
Thanks so much, Angel. As you guys have all been told, my name is Jill. I use she, her pronouns. And I'm joining you from the traditional unceded territories of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh nations in the Lower Mainland of British Columbia. When the government changed in 2015 and unveiled the first gender balanced cabinet in Canada's history, the Prime Minister's response to why half of cabinet ministers were women, because it's 2015, was a good indication of what was to come. In June 2016, the government unveiled the Feminist Foreign Assistance Policy, which included an investment of $650 million over 3 years to address gaps in sexual and reproductive health and rights. This was carried out through partnerships for Her Voice, Her Choice, and one way that Canada wanted to contribute to global efforts to eradicate poverty around the world, recognizing that promoting gender equality and empowering women and girls was the most effective approach to achieve this goal. Not only is sexual and reproductive health, including abortion care, considered an essential part of healthcare in Canada, but the Canadian government has raised it on the global stage. In the context of humanitarian settings, Canada pledged to support the full range of women and girls' sexual and reproductive health needs during humanitarian responses. The government acknowledged that the needs of girls and women can often be overlooked during humanitarian crises. And in light of this, Canada said that it would ensure that its humanitarian funding included provisions for supporting women's and girls' sexual and reproductive health needs, and would raise the importance of this kind of targeted assistance with international partners and at international events in the humanitarian system. This is what feminist leadership can look like. As Julia mentioned in the introduction, 1 year ago today, at the Feminist Deliver conference in Vancouver, Prime Minister Trudeau made a significant announcement that starting with the 2023, Canada's annual contribution to women's and girls' health around the world would be increased to $1.4 billion a year. And that half of that, $700 million a year, would be dedicated to sexual and reproductive health and rights. The announcement identified safe and legal abortion care as part of this investment. In the summer fall of 2019, we saw further evidence of this commitment from the government when they put a call for proposals related to health and rights for women, adolescent girls, and children. And moving forward, we see some lofty goals set by the government. So they've stated that by 2021-22, Canada will devote no less than 95% of its international assistance to initiatives that improve the lives of women and girls. Next slide, please. I'd like to draw on a domestic example that highlights the importance of data and indicators related to abortion care. And while I don't want to single out the Canadian Institute for Health Information, also known as CanWaCH, it is the body that gathers data in Canada on a range of health-related topics. It's a government-controlled nonprofit crown corporation, and it really provides the official numbers on abortion care in Canada. So reporting to CanWaCH for abortion-related information is mandatory for hospitals, and it's voluntary for independent and community-based facilities. And with independent and community-based facilities, CanWaCH kind of takes an invitation approach. So can I have the next slide, please? So while this is the official data on abortion care in Canada, there has traditionally been some challenges with the accuracy of the data. And as you can see from the slide, from 2011 to 2014, there are two sets of data. And this is one of the areas that one of the areas that highlights some of the challenges that have been, that we've had in Canada with the data. So as you can see that there's anywhere between 15,000 and 20,000 abortions were originally going unreported. So in 2015, CanWaCH was able to look at the process that it was doing, mainly for the province of Ontario, which is the most populated, and identified that a huge number of abortions were being unreported. And rather than using their independent clinic process of inviting clinics to provide the data, they found another mechanism to gather it. So that was very promising for the province of Ontario, and it was still unclear on how much data was unreported in other parts of Canada. So for the most part, we see about 100,000 abortions in Canada each year. The number slightly dips in 2016, but really I want to highlight the numbers for 2017 and 2018, which are quite concerning, that we're going back into a situation where we're having gross underreporting of abortions in Canada. In 2017, abortions started being available in primary care and community settings outside of abortion clinics when medication abortion with mifepristone became available in Canada. So as you can see, the drop from 2016 to 2017 of over 3,000 abortions, and then a very significant drop the following year, 2018. It's concerning because many people believe that this represents abortions happening in physicians' offices, in community health clinics and other settings outside of established abortion care clinics. And CanWaCH currently doesn't have a mechanism to capture that data. So we're getting back into a situation where the official data for abortion in Canada is unreliable at best. And this really matters because it's a missed opportunity to tailor supports and interventions. Next slide, please. Another challenge that the data that we have for abortion care in Canada represents is where abortions are happening. So as you can see from this slide, less than 1/3 of abortions are happening in hospital settings. And hospitals is where CanWaCH is able to get the most detailed and rich data. So in addition just to the raw numbers from the mandatory reporting that hospitals are required to do, they're able to provide additional indicators, including the age of the pregnant person, method of the procedure, pregnancy history of the pregnant person, etc. And we miss out on this data from the vast majority of abortions that occur in Canada each year because they don't receive that data from the independent clinics, as well as places that abortions occur outside of established clinics. The lack of adequate and complete data can have impacts on a variety of elements of care, such as funding allocations, personal perceptions of one's own abortion, and efficacy of things that could reduce the need for abortion, like comprehensive sexual health education and access to effective contraception. Next slide, please. Thank you. So the collection and analysis of rich data is important for a variety of reasons, not the least of which is that it can help normalize abortion care. As one of the few countries in the world that doesn't have a law related to abortion care, we have the opportunity to work toward normalizing abortion care as the health care that it is. In Canada, abortion care is regulated by each province and territory, which is one step towards normalizing it both for the patient and for healthcare professionals. Data shows that one in 3 women in Canada will have an abortion during their lifetime. We need to do all we can to work towards normalization. When resources are invested into abortion for things like research, as well as domestic and international initiatives, it continues the work of normalization. Bilateral funding agencies are important as they can signal what a government, as well as what the people of a country consider important. And as I mentioned earlier, Canada has made a great commitment on this global platform. As we outlined earlier, the Canadian government has put forward a feminist global assistance program. We need to ensure the program is more than words and policy. We need to hold government and funding bodies accountable to make the investments in the areas they say they will. By investing in projects that work towards improved health outcomes for women and girls, we are signaling to other countries the value that we place on this. This can have a positive impact in parts of the world that have not focused on abortion care intentionally or unintentionally. There have been intentional attempts made to remove abortion care from women's health and sexual and reproductive health initiatives globally. Canada has continued to show leadership when it recognizes the integral role that abortion care plays in sexual and reproductive health, in maternal health, and in women's health in general. The leadership is also displayed through funded projects and programs. This project has been really important in identifying and developing the evidence stage of advocacy. So as you've heard, we've been able to determine and document that a general lack of indicators related to abortion care exists in humanitarian settings. This information will help inform our further advocacy activities. We'll be able to use the information that we've gathered to demonstrate how key issues can be overlooked and or addressed inconsistently without guidance. And I think the CanWaCH example is one that really highlights how that's been happening here in Canada. We'd like to help build the capacity of Canadian funders, particularly the Canadian government and Global Affairs Canada, to show the impact they can have by requiring the collection of abortion-related indicators into funding applications and reporting processes. When we engage with decision makers, both elected and non-elected, we can help translate what occurs in humanitarian settings and what appears in reports into tangible, actionable results. Results from this project will support Canada's role as a global leader in sexual and reproductive health and rights, particularly as it relates to abortion care. Should abortion care indicators become a requirement of future funded projects and reports, we can help push the dial in centering women's health and rights by keeping abortion care front and center, not only in Canada, but globally as well. While this could directly impact humanitarian settings, it has the potential for broader reach. A change that appears to be small, like adding indicators to reporting, would support Canada's feminist foreign assistance goals and feminist agenda. The case of CanWaCH shows that when data collection is mandatory, we get richer information and it can have many concrete uses. One example of the Canadian context is that better understanding the age of demographic of pregnant people who access abortion care can help target education and resources where they're most needed. An example in humanitarian settings includes ensuring the agencies providing support and services match with the needs of the women and girls in those areas. Next slide, please. So we have a lot of people that Angel has mentioned and some folks that we have not yet mentioned that we've been working with, and we just want to give our thanks and appreciation to all the individuals, many more than who are listed here, who have been working with us and contributing to this project. Thank you.
Thank you so very much, Jill and Angel, both of you. I think it's safe to say that you've given all of us a lot to reflect on, and it's really exciting to see this project that has built the strong foundation for evidence, and I'm sure many of us here will be following closely along as we see how you mobilize it into action. And what I've really resonated with is how you both laid out very strong linkages between the conflict and fragile settings, but also in Canada, where the goal still remains to normalize access to safe abortion, and the core means of that being with abortion-related data. So really thank you for really laying out that complex landscape that we're all trying very hard to understand. And I'm happy to say now we're in our discussion period. So, and I'm lucky to be joined here by my colleagues, but as well as Angel and Jill. And so we encourage participants to enter questions throughout the Q&A. However, we've already collected a few from responses earlier. So if I can batch a few questions for you, Jill and Angel, based on what we're seeing here in the Q&A, particularly from Maggie, from the questions around incorporating CanWaCH and abortion data. So once consolidated, what are the steps and obstacles for countries and organizations to start the implementation of using such consolidated data collection? Would there be needing consensus from stakeholders and government health agencies, investments from donors? I'll leave that as with the first question. So, Angel, you are muted. Wonderful.
I'm happy to take a first stab at this one, and just to say that I think that there are a lot of ways, once there is some degree of consensus about what this core set of indicators is, both around SRH more broadly, and then also the abortion-related component, I think there are a number of avenues to facilitate this. There's certainly a ground-up approach, which is one of the things we're doing as part of this collaborative, which is to develop tools and resources, work with partners in a broader array of countries to sort of pilot the implementation of those resources, and then provide evidence that these tools actually can facilitate that uptake. And without trying to overpromise from the WHO's indicator project, I know that's part of their envisioned process as well. But I also think that there's a top-down approach where some of this advocacy becomes really essential. And one of the things has to do with this accountability. How is it that we can set standards, normative standards for collecting this kind of information routinely? And one of the ways that we do that is through bilateral funding agencies. Another way that we do that is incorporating specific information about data collection expectations into global resources to the guidance from normative bodies. And I think this moment of really capitalizing on where the Canadian government is in terms of both supporting SRHR and really recognizing that abortion is a core component of that, and the Canadian government's real commitment to supporting accountability means that this is an agency that we think could have a strong role in shaping what is collected routinely. Jill, I don't know if you have anything else to add.
I would have said much of what you said about the role that the Canadian government plays in that, so thank you.
Oh, well, thank you. Thank you so much, Angel and Jill. And I mean, we have a few particular questions around the data that we saw. So did the data or indicators also include impact on women, and more particularly around perceived social support being offered to women? I think this is referring to the CanWaCH data particularly.
Oh, the CanWaCH data does not capture that kind of more detailed qualitative data. So it tends to be information that can be gathered from a patient's chart in a hospital setting, which is why it's mandatory in that setting.
Okay. And I think there's a following question around the CanWaCH data. So was the CanWaCH data of induced abortion numbers in Canada, including or excluding medical abortions and or abortions from doctor offices versus clinics?
Yes. So that's actually one of the most significant challenges with the data. And I should say, because I don't want to completely single out CanWaCH, that I've had, that's been some of the advocacy work that NAF Canada has been doing, has been working with them to see if we can come up with alternative methods to gather data, because they are also aware that this is one of the shortcomings of the mechanisms that they're currently using. It mostly excludes any abortion that is occurring outside of hospitals or the established, I'm using sort of established, but like the long existing abortion clinics and facilities that they are aware of.
And I think that leads us to the broader question around the data that is being collected through this project, hopefully to set a stage for what CanWaCH could be collecting in the future. So a combined question of what is the rationale for selecting the countries that you have in this project? Is it based on feasibility and willingness of collaboration of in-country partners? How did you address specifically data collection in countries where abortion is legally restricted?
So here, just to say that for the CanWaCH project, we were really trying to select initial countries where there was some regional diversity, where there was different types of conflicts in terms of, or emergencies in terms of duration, and where the location of refugees was actually different. So thinking about context where refugees are concentrated in refugee camps, where they're split between refugee camps and urban areas, or where they're predominantly in urban areas. We also really wanted to include in our initial set of countries with a diversity of laws around abortion, from in our first three, from Bangladesh, where menstrual regulation is legal, to Jordan, which is sort of a mixed status country where abortion is legal for certain indications but not others, and Somalia, which is much more legally restrictive, to really see what this means in terms of collecting data in different regulatory environments. The WHO project expanded that even further to really incorporate different regions, to ensure that there were different epidemiological profiles that were captured by the set of countries, to really look at the nature of the emergency. And so, for example, one of the reasons that Albania is a candidate country is because this is an emergency that was really set off by a natural disaster and a very specific temporal moment. And so there's even greater kind of diversity. And I'll also just say different capacities for reporting and collecting information. So different strengths of national data collection systems, if you will. So I think there's a lot of intent behind the candidate countries. Having said that, feasibility is always going to be something we're going to take into consideration. And we also have to have strong local partners who we can work with. And some of that is about longstanding relationships. Some of that's opportunistic. Some of it's in the sense of having windows of opportunities. So that certainly has shaped some of this as well. There was a question I saw, which was about Latin America and whether there was an intention to include a Latin American country. We aren't doing our initial assessments in a Latin American country, but our intent is to include one Latin American country in this phase of developing and testing these resources. Whether or not that's feasible is still sort of in the works. And again, a lot of things are shifting, if you will, because of the COVID-19 situation, but it is our hope that that would be one of the countries where we could actually look at the development of these tools and resources to see if they would be applicable.
It just goes to show how much work there is ahead of us. Really. It doesn't stop, which is, unfortunate, but at the same time, really great to see the championing that you both are doing. And so it leads.
I will say too, the question about collecting data around abortion in legally restricted settings. And again, this is just, for our project, we're really focused on facility level data in terms of the services that are provided. And in all of the countries that are included in the study, abortion is legal. It was legally permissible for at least the indication of saving the life of the woman. And so we have not included in this study any country where abortion is legally prohibited in all circumstances. And because of that, and there aren't very many countries for which that actually applies. And because of that, it means that there are legal indications for abortion. And so collecting this is sometimes about abortions that may fall outside of the law, but often would be abortions that would fall inside of the legal exceptions, even in countries where abortion is legally restricted.
No, and I think that's where we're at. There's a lot of gray zones with respect to understanding where interventions can be with respect to data. And so that's the next question. So how do we move beyond the numbers and highlight the actual impact of SRHR initiatives and advocate the need for more work in respect to the humanitarian context in SRHR? I think that's towards you, Angel. Yeah.
So let me say first that at my core, I am a qualitative researcher. I'm trained as a medical anthropologist. I think actually digging deep into people's lived experiences, how policies and services affect real people is critical. And I think that should be a core component of our programming. That, however, isn't the primary objective of this project. And here I just want to go back to using this less is more model. And I know this is really unsettling sometimes to researchers who want to have much more information. And because we're doing this work in so many settings, would really love to hear much more. What does this mean for X, Y, and Z? We've really tried to approach this from what is that essential information that we can use as a starting point that could be feasible to be collected everywhere. And then as there is growing confidence in collecting that information and knowledge that that information is informing programming and is useful, then it may be possible to expand out. If not the actual sort of guidelines or requirements, then individual settings may want to capture much more of that information and have more robust work. And so for now, we're kind of sticking to this less is more in this really narrowed scope. And there are trade-offs with that.
Absolutely. Jill, did you want to offer anything to that?
Well, I agree with that concept of, for many places, less or more is a really great starting place. And I think when Angel had talked about one of the settings that we were conducting research, and they said that it was unnecessary because no one's having abortions. To me, that really sort of highlights even beginning to collect a small amount of data can really help change some opinions and impacts.
Yeah, absolutely. And I think, you've all touched on capacity building to some degree as to what Canadians can do in our own respective spaces. And so a question that we have for you is, Angel, as well as Jill, you've mentioned that sometimes organizations are confused as to whether they should be collecting abortion data and don't know the laws in the country in which they're doing this programming work. Many organizations on the call today are working in diverse areas of SRHR. How might they apply the findings from the work you are doing in abortion data to their own work? Do you have any recommendations for anything they should collect, or even further in terms of capacity that they could build?
Jill, you want to start? Or
sure, yeah, sure, I'm happy to start that. I mean, I think that, just sort of looking at overall the process, there's obviously opportunities for learning there, as well as how successful the partnership's been. But I just wanted to highlight one thing that really wasn't exactly part of the question, but I think is really important. I think we also need to acknowledge that, gathering data is additional work, and so it really needs to be things that are funded. And sort of coming from that perspective of, how can we better support donors to recognize that they need to fund those. I think other learnings, it would be, an opportunity to so now we've highlighted that specifically for abortion care, there can in many places be a lack of data that's gathered. So maybe looking in the areas that they're working in, or is there something that's maybe more stigmatized or less common that they might be, they might also have an area that's underdeveloped, like abortion care is in many places. Sort of one of the things I can think of.
And I guess for me, one of the things that I would just leave us all to consider is that, abortion is a part of women and pregnant people's lives all over the world, irrespective of context, irrespective of whether it's humanitarian development or develop. It is a part of women and pregnant people's lives, irrespective of age or dominant religion within a particular country or setting. And it's an important part of people's lives, irrespective of legal status. And one of the things that I think is a starting point is if we start to integrate abortion and questions about abortion into the other work that we do in SRHR, it helps normalize abortion. And so for those folks who are working in a broader array of SRH issues, but maybe don't include abortion now, I would challenge you to think about what are some ways that abortion content could get integrated? What would it mean to add a question to the way that we talk about abortion when we're talking about the pregnancy history of the person who's in front of us, or how it is that we're collecting information in our own institutions, or what it is that we put on a survey, or how it is that we approach this. It may not mean necessarily that always those data are going to be of high quality, and that sometimes needs to be worked at over time. But by not asking about abortion, we've effectively siloed it and we ignore it and we pretend like it isn't part of SRHR when it is an inherent part of SRHR and of maternal and child healthcare.
That's a really powerful statement, I think, to leave us all with resonating on. And I think that brings us to, once again, the Canadian political context, as the lines are blurring, with respect to COVID as well. So for your Canadian political advocacy plans related to the feminist foreign assistance policy, are you working in coordination with WPSN at all? They have a subgroup that is working with GAC and specifically looking at the ELSI initiative. And one aspect of that is to ensure SRHR access for all Canadian uniformed women supporting global humanitarian missions, and or for Canadian uniformed healthcare providers to also have access to SHR options for use in their humanitarian related healthcare provisions. A little bit of a statement, but
there are a lot of elements to that question. So due to COVID, because this is a healthcare issue, and obviously COVID is a healthcare issue, just start off saying that a lot of our activities have been pushed back. This was really coincided in the time when we were really gearing up. So we're looking at other ways to try to deal with advocacy, recognizing that we're in the middle of a health crisis around the world as well as in Canada. So one of the stages that we're at now is looking at organizations that we can work and partner with and look at how we can work together and build up the voice. And then hopefully when the government is more in a place where they're able to focus on other topics outside of COVID, that we'd be able to approach them. So we have not yet approached WPSN, but would be open to working with them. And I think there was a question about the military or women in uniform in other settings and whether that's part of, something that we're focusing on.
Yeah, sorry.
I would just say in response, and I think it was Karen's question in terms of the Women, Peace and Security Network and looking at what's happening with Canadian uniformed personnel. I think this is a great example of how the domestic and the international are actually intertwined, and why sometimes our advocacy gets really separate and we think about domestic work and we think about international work. And in fact, there's a lot of overlap, and I think Jill's presentation really showcased that and how these things are intertwined. But I think that question is also in this space, which involves Canadian personnel who are working in international, who may be working in international settings, for example, and how it is that we need to meet those needs in a variety of different contexts. I think our hope as we move forward with and sort of transition into more of the advocacy work, COVID-19 situation permitting, is that we will be able to build some of those alliances with groups that are working in this space, both domestically, internationally, and in this liminal space, if you will.
And I think that much like abortion care has been siloed with sexual and reproductive health and other kinds of health care, that to some degree, advocacy has been siloed to specifically domestic and to global. And that's one of the great things about this collaborative is it's really an opportunity to find ways to bring them together and to amplify efforts both on global and domestic levels.
I think you're on mute.
Okay, well then. Well, I think on that note, I'll leave with the one last question of the fact that your alliance is a really strong one. And I mean, we all felt it, I think, through this webinar today. How did this partnership between University of Ottawa and National Abortion Federation Canada come to be? And can you leave us with the unique strengths that this partnership is propagating into your work and on this topic overall?
I'm happy to start.
Sure.
That's okay. Yeah. So NAF Canada has been involved in all elements of abortion care, including advocacy, since its inception. However, it really has focused mainly on domestic issues. And so this partnership has been really valuable to look at where the strengths of NAF Canada lie and where we can also raise that up to a global level, because we do recognize that we're quite privileged here in Canada and that we have an obligation to work beyond our borders. And one of the things that's happened also since our partnership is that NAF Canada has been looking at the work that we're been doing, which has been domestic, and have been exploring the opportunities to work with some partners in the global south to strengthen the work that they're doing, and also to strengthen our work, looking at what's happening outside of Canada.
And I mean, from my perspective, it's been tremendously valuable to have such a great advocacy and policy-oriented partner that's also entirely committed to evidence-based advocacy. And as the research part of this partnership, having that kind of advocacy partner is really key. NAF generally, NAF Canada, but also the NAF affiliates in other countries actually produce a lot of the evidence that we use for clinical practices that really do support best practices. So there's these really nice links, I think, between the research and advocacy. And again, really trying hard not to silo those. And so it's been great. It's been a great partnership in that way too.
Well, thank you so very much, both of you, for relaying to us just all the complex work that is going on behind the scenes. And I'm going to turn it over to Jessica Ferne to leave us with some closing remarks.
Thank you. And to just on behalf of all of us here at CanWaCH, I want to share our gratitude to Angel and Jill for their presentation today. As you've Julia started us off with, remembering that this today marks that 1-year anniversary since the commitment of Canada to fund many areas of women's health and rights, including neglected areas of SRHR. So I really can't think of a more important and exciting conversation to be having today. And as a data person and a programming person, the collaborative initiative is one that's really near and dear to my heart, because it really gets at addressing some of the urgent gaps in our knowledge and our understanding that keep us from being able to support the health and rights of women and girls in their communities. And this partnership between University of Ottawa, NAF Canada, and all your global partners, I think really first highlights that global to local connection and the universality of our need for quality data, and just how important it is to fund this kind of inspiring, creative thinking and exploring new strategies, creative strategies to address these gaps. We had lots of questions still in the chat that we didn't get to, so I think that just goes to show we'll have to have conversations in future, certainly after that ongoing work that happens in the fall that Angel mentioned. Our contact information was up on the screen. Feel free to reach out to us if you have any questions or want to know a bit more between now and then, or to reach out to Antu and myself at metrics@canwatch.ca if you'd like more details on the collaborative and upcoming initiatives. And then finally, just a quick plug for next session that we'll be having. So next week, we'll be having a conversation on another one of our labs. And in 2 weeks from yesterday, we'll be having the launch of an exciting new report that looks particularly at the implications of COVID-19 on data research and evaluation. So if that topic is of interest to you, you'll definitely want to check that out, and you can visit our website for more information. So once again, on behalf of all of us at CanWaCH, thank you so much, Angel and Jill, for your time today. Thanks to all of you for joining us, and I know we'll see you again soon.